Welcome to the Pulse Point Sisters. Myself Paramita Chatterjee, Masters in Critical Care Nursing. So today's our topic is on paroxysmal supraventricular tachycardia. What is supraventricular tachycardia? Supraventricular means above the ventricles. Supraventricular means above the ventricles, and tachycardia means heart rate more than 100 beats per minute. Okay. Then so there is tachycardia and tachycardia above the ventricles. So tachycardia that is generated on SA node or tachycardia generated from the AV node, that is called supraventricular tachycardia. It has many types supraventricular tachycardia: atrial arrhythmia, atrial flutter, atrial fibrillation, and atrioventricular nodal reentrant tachycardia. This is the main important discussion point: atrioventricular nodal reentrant tachycardia. And another one is Wolff-Parkinson's-White syndrome. This is also important. What is Wolff-Parkinson's-White syndrome? There is Wolff-Parkinson's-White syndrome. Here it is the congenital abnormality. Congenital abnormality means here one abnormal pathway is present from the childhood. One abnormal pathway. Normally what we know, impulse generated from SA node, then current flows down AV node, then current flows to the bundle branches, then Purkinje fibers. Here what happened, current flows from atria to ventricles through a abnormal pathway. This pathway, SA node, AV node, then bundle branches, then Purkinje fibers, not followed. Here current flows from the atria to ventricles through a abnormal pathway. And what happened for that reason? Here pre-excitations of the ventricles. Result is pre-excitation of ventricles. আমরা দেখছি যখন আমরা এসি নোড থেকে এভি নোডে কারেন্ট এলো এবং এভি নোড থেকে বান্ডেল অফ ব্রাঞ্চেস হয়ে পার্কেনজি ফাইবার্সে যাচ্ছে, তখন ভেন্ট্রিকলসের মায়োকার্ডিয়াম স্টিমুলেট হচ্ছে। বাট এক্ষেত্রে কি হচ্ছে, এক্ষেত্রে আর্টেরিয়া থেকে ভেন্ট্রিকলে অ্যাবনর্মাল পাথওয়ে দিয়ে কারেন্ট ফ্লো করছে এবং তার ফলে ভেন্ট্রিকলস স্টিমুলেট হচ্ছে, এবং এই স্টিমুলেশনটা অনেক আগে হচ্ছে, বিফোর দ্য নর্মাল পাথওয়ে. So pre-excitation of ventricles present here in Wolff-Parkinson's-White syndrome. And what we get in the ECG findings? In ECG findings we get delta wave, slightly longer QRS complex. So basically if we look at this situation, here the normal P wave present, PR interval shorter due to presence of delta wave, PR interval shorter, and premature ventricular tachycardia জন্য premature pre-excitation of ventricles এর জন্য আমরা এখানে slightly longer QRS complex পাচ্ছি, যেটাকে আমরা ডেল্টা ওয়েভ বলে থাকি। আমরা ডেল্টা ওয়েভ ইন QRS কমপ্লেক্সে একমাত্র WPW সিন্ড্রোমেই পাই। P wave normal, PR interval shorter, and delta wave present in QRS complex. This is the main characteristics of ECG findings in WPW syndrome. Another one, this is the most important, atrioventricular nodal reentrant tachycardia. What happened in atrioventricular nodal reentrant tachycardia? Here is the different types of supraventricular tachycardia. We are focusing on AV nodal reentry tachycardia. AV nodal reentrant tachycardia. Picture of different types of supraventricular tachycardia. Current flows from SA node to AV node and from AV node to ventricles. What happened in AV nodal reentrant tachycardia? Current flows from SA node to, normally current flows down from the SA node to AV node and AV node to bundle of His and then Purkinje fibers, but current does not flows back to the atria. Current does not flows back to the atria. But what happened in AV nodal reentry tachycardia? Current flows back. Current flows back to the atria from ventricle to atria, and forming a loop, and this loop again and again excite and stimulate the atria and ventricle and create a supraventricular tachycardia. So this is the problem of supraventricular tachycardia. Then what will be the presentation of supraventricular tachycardia? Patient may complaining palpitation, dyspnea, syncope and dizziness. Neck is bounding, means shirt flapping is present, and urinary urgency means polyuria. What is shirt flapping? Heart is beating such a fast rate, carotid are pushing blood again and again to the brain and resulting in flapping in shirt. Patient is complaining palpitation, dyspnea and chest pain. So we misdiagnose the patient with panic attack. These are all signs and symptoms of supraventricular tachycardia. Then we go for ECG findings. What we get in ECG findings in paroxysmal supraventricular tachycardia? Rate 100 to 300 beats per minute. Rhythm irregular. P wave abnormal shape may be the hidden in the preceding T wave. PR interval shortened. QRS complex normal usually and ST segment depressed. QRS complex, narrow QRS complex we get in supraventricular tachycardia. Here we see rate 100 to 300 beats per minute and rhythm is irregular. Why rhythm is irregular? You see the distance between RR interval is not equal. Distance between RR interval is not equal. This is called rhythm irregular. P wave abnormal shape and hidden and buried in QRS complex. Here we see another ECG findings. This is also supraventricular tachycardia ECG findings. Here we see T wave, T wave, T wave, T wave, no P wave present. P wave buried in QRS complex and QRS hide the P wave. And we also clearly see in this ECG shorter QRS complex. Shorter QRS complex. Normally QRS complex duration is 0.12 second. Means one small box 0.04 second. So it usually in QRS complex 3 small boxes are there, 0.04 into 3, 0.12 second. But in supraventricular tachycardia only one box we get here. So this is narrow QRS complex. This is the main feature of SVT. Narrow QRS complex, less than 3 small boxes we can get, 1 small boxes we can get in ECG findings. Then go for this is another ECG findings. Here also we see rarely visible P wave and heart rate above 150 beats per minute and narrow QRS complex. Narrow QRS complex. Then go for treatment and management of supraventricular tachycardia. Here we see Valsalva maneuvers, carotid sinus massage, injection adenosine administration and abolition of accessory pathway. First one, protocol. According to protocol, if shock is present, if patient come with palpitation, dizziness, pre-syncope, you have to do first check the oxygen saturation, give oxygen and IV access, insert IV, put the patient in 12 lead ECG, then check shock, chest pain, ischemia and heart failure sign. Then go for management. If patient have shock presentation, then first vagal maneuvers, we'll discuss about the vagal maneuver later. Then immediate DC cardioversion. Before DC cardioversion, you sedate the patient, then give the synchronized shock. First 70 to 120 joules, then it increase it 120 to 360 joules, and then check magnesium, potassium, calcium and correct it, and give injection amiodarone 300 mg IV over 20 minutes. Then again shock the patient if the patient is not getting better. And another one, if the patient is not shock condition, first monitor the patient, put the patient on cardiac monitor and take the 12 lead ECG and ensure the trace recorder is on. Then go for vagal maneuvers. What is vagal maneuvers? First, carotid sinus massage. Carotid sinus massage, you press on the carotid artery, stimulate the vagal nerve, and vagal nerve slows the heart rate. First check the carotid root before you press the carotid artery. If rhythm is irregular, then you treat the patient as a treatment of atrial fibrillation. Then vagal maneuvers, this is the vagal maneuvers, and another one is the Valsalva maneuvers. Valsalva maneuvers slows down the heart rate, also the tachycardia. You give the patient an empty syringe and ask the patient to blow the syringe. You can stimulate the vagal nerve. When the patient blow in the syringe, it stimulates the vagal nerve and slows down the heart rate. What is modified Valsalva maneuvers? First one, you give the syringe and ask the patient to blow the syringe 15 seconds in semi-recumbent position. After 15 seconds, elevate the leg 45 degree and then wait for 15 seconds, and after that put the patient in semi-recumbent position and then check the rhythm in ECG. This is the modified Valsalva maneuvers. First, give the patient one syringe and ask the patient to blow the syringe 15 seconds in semi-recumbent position, and after 15 seconds elevate the leg 45 degree and then wait for 15 seconds, and after that put the patient in semi-recumbent position and then check the rhythm in the ECG. After Valsalva maneuvers, we go for IV adenosine. IV adenosine, the dose is 6 mg IV bolus, and 6 mg IV bolus in large vein followed by 0.9% NS IV flask. 6 mg IV bolus in large vein followed by 0.9% normal saline IV bolus. After 2 minutes, give 12 mg. And if patient not getting better, give 12 mg third time. This is the dose of adenosine. If adenosine is contraindicated, then go to another protocol. This is ABCD. If adenosine is contraindicated or adenosine is failed, then go for beta blockers, calcium channel blockers and also digoxin. Calcium channel blockers, verapamil 5 to 10 mg. Beta blocker we give metoprolol and then digoxin. This is the ABCD formula. If all the procedure fail, Valsalva maneuver fails, adenosine administration failed, then last one is synchronized cardioversion, and after that another one is electrophysiological study, where the origin of current we find out, where the origin of abnormal current, sources of abnormal current we find out and ablate this place and cauterize this place. This is the catheter ablation therapy in supraventricular arrhythmia or electrophysiological study we done. So these are all about the supraventricular tachycardia. First we know about what is supraventricular tachycardia and what are the types of supraventricular tachycardia. then the Wolff-Parkinson's-White syndrome, another one, and AV nodal reentrant tachycardia. Then the ECG findings of WPW syndrome, delta wave is present in WPW syndrome, and AV nodal reentry tachycardia we may get rhythm irregular P wave baryton QRS complex and narrow QRS complex, shorter QRS complex. This is the main features of supraventricular tachycardia. Then management of supraventricular tachycardia: if shock present, we give oxygen, vagal maneuvers and DC cardioversion, and after that we give injection amiodarone 300 mg over 20 minutes. And if shock is not present, then we go for vagal maneuvers, IV adenosines. If IV adenosines fail, then we go for BCD approach, beta blocker, calcium channel blockers and digoxin, and then we go for DC cardioversion and synchronized cardioversion, and then last one is electrophysiological study. So that's all. Thank you.